Okay, so we're going to go ahead and get started. Today, Sumin and I are going to talk a little bit about evaluating LV size and LV function by CMR, and then Sumin is going to talk about the same by CT and nuclear. And then next week, Dr. Naga will talk about evaluation of chamber size and LV function by echocardiography. We had to switch things around today because Dr. Naga is out of town. So to start with, obviously, accurate assessment of both chamber size and function is critically important in a variety of different heart disease conditions. And so as cardiologists, this is probably one of the basic pieces of information that we try to derive. Now, typically, your assessment is going to start with echocardiography because it's low cost, portable, has widespread availability, but there can occasionally be limitations with the echo, such as suboptimal acoustic windows. There's some operator dependence. And then also, as Dr. Naga will talk about a little bit next week, there can be the need for some geometric assumptions. And so as a result, there oftentimes can be a role for CMR for assessment of chamber size as well as LV function because of the high spatial and temporal resolution offered by CMR, excellent signal to noise, free choice of imaging planes, and then most importantly, I think, is the lack of need for geometric assumptions in doing our computations. So what am I going to try to do here over the next probably 40 minutes or so? I'm going to try to talk a little bit about how Cine CMR is performed. We'll go into some of the limitations and then also strategies on how to overcome some of these limitations. And then we'll finish off by talking about how we use the images to then post-process and derive volumes as well as ejection fraction. And then also go over some of the important differences for volumes and ejection fraction based on age as well as gender. And then finish off by looking at how the two techniques compare, CMR versus echo. So here's an example of what a typical study would look like if a patient were referred simply for assessment of LV function. We would acquire essentially a series of these short axis slices from the base of the heart all the way down to the very apex of the heart. Now, and these are done typically every 8 to 10 millimeters apart. So we're not just obtaining 1 or 2 or 3 short axis slices, but really every single short axis slice to cover the entire ventricle. And then in addition to that, we're going to get the standard 2-chamber, 4-chamber, and 3-chamber views, the long axis views of the heart as well. Let's skip forward here. The key things with this, if you just want LV function assessment, doesn't require an IV, doesn't require the need for contrast, and this study can really probably be performed in about 10 minutes. So it's actually a fairly fast assessment for LV function and volumes. Now let me take you down a little bit under the hood to go into kind of how it is that we actually do the image acquisition for Cine imaging to look at volumes and function. And so a couple of things I think to keep in mind is that most CMR acquisitions are done using a strategy called segmentation. Now, does anybody here know what segmentation is? And by this, I don't mean trying to segment out the heart as in polarimeter or trace the heart. Anybody have an idea what we refer to when we say CMR techniques are acquired in a segmented acquisition as opposed to in a real-time acquisition? No? Okay. Throughout what? Correct. So that's actually right. So these images are actually taken over multiple cardiac cycles and then put together to generate one cardiac cycle worth of data. All right. And so the important concept of segmentation is that if I have one heartbeat, I acquire some lines of data that I'm going to use to generate my image, and then I come back again with the second heartbeat, acquire additional lines of data that I then add to my image matrix to fill in all the lines of data that I need to generate my image. Now the one difference is, for example, for those of you in the echo lab with some 3D echo techniques, or those of you in the CT lab with CT techniques where you're actually acquiring different data and then stitching it together to generate a full volume, the difference with CMR fundamentally is that each line of data that you acquire somehow contributes to the formation of the image. So when I say that I acquire part of my image during the first cardiac cycle, it's not that I'm actually acquiring the first quarter of the image. I'm actually acquiring a quarter of the lines of the data that I'll use to generate the image, but I can't actually reconstruct the image with just the quarter of lines of data. But the image will look like this. So it looks like a lower resolution image. And as I acquire more and more lines of data, I can keep reconstructing, and I keep reconstructing a higher and higher spatial resolution image. So the reason for this is because if we have errors that occur, for example, if things are not exactly the same each cardiac cycle as I'm acquiring the data, then the artifacts that it will lead to is not the standard stitch artifact that you're used to where things look like they're misaligned, the top half or the bottom half of the image, but it produces a slightly different type of artifact, and we'll go into that in a second. So this is an example of a still frame image that I wanted to acquire, where I would acquire all of my lines of data typically in mid-diastole when the heart is stationary, when it's not moving. But what if I want to acquire motion images? I want to acquire Cine, what we call a Cine loop. That's actually done by acquiring a series of images at slightly different points within the cardiac cycle. And so here's an example of kind of a standard Cine acquisition scheme where I would actually want to acquire typically a frame every 40 milliseconds after the onset of the R wave. And I'd want to generate one image that represents time 0 to 40 milliseconds, a second image that represents the time 40 to 80 milliseconds after the onset of the R wave, and then keep doing that for the full duration of the cardiac cycle. So what we would do then is with the segmentation strategy is I would actually acquire a few of the lines of frame 1 in the first cardiac cycle, and then also some lines for frame 2, some lines for frame 3, all the way to, let's say I have 20 frames. And then the second cardiac cycle, I would do this again and acquire more lines, bin those into frame 1. The next 40 to 80 milliseconds go to frame 2, and on for the full duration of the 20 frames or whatever I'm acquiring. And then once I'm done with that, if I take these individual images and play them one after another very fast, I now have a movie which gives me the appearance of wall motion or contractility. Now, a couple of things to keep in mind, and these are when things can go wrong. And these can be either patient-specific factors or it can be operator-specific factors. Okay? So here's an example. And so I think it's important for us, when you see the images, to be able to tell what's the problem with the images here, to then know how to troubleshoot it. So what's a problem here? So first step is what's wrong? Look at this acquisition and what do you think about it? So here's a patient. There's a short axis view of the heart. Again, this is a segmented image, so we ask him to hold their breath, and we require this over about 5 or 6 cardiac cycles. And what do you think about this image right here? Looks okay, or there's a problem? And if there's a problem, then what's the problem? Was that? Not holding the breath. Okay. That's the wrong answer. I'll tell you why in a second. Any other thoughts on what's wrong with this? Was that? Okay, Danny? Okay, yeah, because if you look at this, you see the onset of the systole, and all of a sudden it just stops and starts all over again, right? So what's happened here is that we're missing part of the cardiac cycle. So we're missing basically the latter parts of diastole. So the problem here is, and if I showed you in that example where if my RR interval is 800 milliseconds, I want to have frames that go all the way out to the very end. If I set the acquisition window too short, then I miss the last 200 milliseconds of the cardiac cycle. And then the image looks kind of jerky like this, where it looks smooth, and all of a sudden it pops back out again. All right? So this is a operator-specific factor. The technologist set the acquisition window too short. All right? Now here's another example, and what do you think about this case? So describe what it looks like. So, okay, so somebody said it's missing systole. Now, is it missing, if you look at it, you see all of systole here, right? But then it's missing the second systole, right? So what's happened here is, in fact, it's not that I'm missing systole, it's that I've actually acquired too long of a period of time. So I've acquired one full cardiac cycle, and I start to actually acquire part of a second cycle, and then I stop, right? Does everybody appreciate that? So as a result, you start to see the second systole, and then all of a sudden the loop starts all over again. So the problem here is that again, this is an operator-specific error. The acquisition window was set too long. So if the patient's RR is 800 milliseconds, we've set the acquisition window too long. The scanner, if I'm doing a perspective gating strategy, the scanner just says, I'm going to acquire data once I see an R wave and keep acquiring for 1,000 milliseconds if that's what I set. It doesn't matter that there's another R wave that happened in the middle. All right? So this can happen, one, if the technologist is not paying attention and they set the window too long, or more commonly, it's where it looks like the R interval was longer and then the patient sped up, but the technologist didn't make an adjustment. And so the key here is that every acquisition, with every breath hold, you've got to relook at the EKG signal and figure out what the correct parameters are and make adjustments if there's changes that happened. Okay, so here's another example. What do we think about this one here? So take a look at it, and how does it look?
Seems like there's partial voluming.
Okay, partial voluming in what way?
Like the LV is not heterogeneous. It's not homogeneous.
Okay, and so it's is it the endocardial or the epicardial borders? The epicardium or the endocardium? If you take a look at this, because also if you look in diastole, how does it look? And let me pause this for you to make it easier. How does this look here? And diastole looks good, right? It's actually during systole when there's movement, right? That it doesn't look very good. It looks blurry, right? And the endocardial borders look blurry. I can't really define the borders that well. This is a problem of frame rate or temporal resolution, okay? So that, remember I said ideally you want to take each frame to represent about 30 to 40 milliseconds of the cardiac cycle. So that means a frame rate of about 20 to 30 frames per second. If the frame rate is too poor, then this is the problem that you run into, right? So instead of having a frame rate of 40 milliseconds here, we've got a frame rate of 80 milliseconds. So these are not cases, I don't want to besmirch our text. These are cases we specifically did erroneously on purpose to try to show the errors that can occur, all right? But this is an example. If the frame rate's not sufficient, then the image looks blurry, right? It looks blurry in systole, but diastole itself looks just fine. And then here's one last example, Cine. What do you think about this one here? So the things you look at is, am I capturing an entire cardiac cycle? Am I missing part of a cycle? Am I capturing over one cycle? Then look at how does the contraction look. And again, that's a function of your frame rate. If systole looks blurry, that means the frame rate would be bad. If systole looks nice and smooth, that means I've got an adequate frame rate. And in this case, all those things look fine, right? If anything, it looks like I can see systole very smoothly. And in fact, this is an example where there's nothing wrong. We've got very high temporal resolution. These are actually 10 milliseconds a frame, so 100 frames a second. So the thing with MR is I can dial in whatever resolution I want. I can make the frame rate 30, I can make it 10, I can make it 100, right? Now, there's going to be some differences though, and the question is, in the left example where I had a frame rate that was poor of about 10 frames per second versus the right where I've got a frame rate of about 50 or 60 frames a second, what's the difference in the breath hold time? Right, if I get a higher frame rate, it's going to take more cardiac cycles to generate more frames. Therefore, the breath hold time is much longer on the right-hand side versus the left. So whereas the left was about a 2 to 3 second breath hold, the right-hand side was about a 30-second breath hold, right? So the issue again is typically we try to achieve a frame rate of about 20 to 30 frames a second, but sometimes you can dial it up or down however you want. And so the optimal frame rate for any patient is whatever the highest rate they're able to tolerate, right? Because it doesn't make sense to try to go for an ultra high frame rate like on the right hand side if the patient can't tolerate that, they can't hold their breath that long. And I'll show you now what happens then. Let's skip forward here. In the setting of arrhythmias, okay? So what I showed you before was if patients have a normal heart rate, then the segmentation strategy works. The standard strategy. What happens here, this is a case of ventricular bigeminy. And if I use that same standard approach, these images look quite blurry, right? So the question is, what can I do then, or am I just left with this, right? So the issue is, there's strategies you can employ, and the first thing when we're trying to tackle arrhythmias is to really kind of determine, are we dealing with a regular rate, or a regularly irregular rate, or an irregularly irregular rate, all right? Now, what do I mean by that? If you look at it, if you think about it, bigeminy is actually a regularly irregular rate, right? There's a normal QRS and a PVC, normal QRS and a PVC. So for bigeminy, there's actually a strategy that you can employ, which is to actually fool the scanner. Instead of, so say, okay, well, I know that there's going to be a normal heartbeat and a PVC, and the combination of the two maybe take up, instead of 800 milliseconds, it takes up 1500 milliseconds of time. So I can actually fool the scanner into essentially acquire both beats. But then since the combination of the two repeat itself over and over again because it's a regular to irregular rhythm, I go from what looks like on the left-hand side to now what it looks like on the right-hand side, where I see a nice normal contraction for the normal beat, and then I see the PVC beat as well. And I'm imaging the entire PVC beat. So with a regular to irregular rhythm, you can try this strategy right here. The problem obviously is if it's irregularly irregular, such as AFib, or if I have frequent PVCs, that's not going to work. And I'm going to have poor image quality. So what can I do then? So there are some tricks that you can apply then as well. One is this thing called arrhythmia rejection. So what I would do is I would say, okay, and this works great if you have occasional PVCs especially, where I know that if when they have normal RR intervals, it's let's say 800 milliseconds. Then there's a PVC that falls early. But what I can do is I can tell the scanner, discard any data that falls outside of a certain window. So if I know that it normally is around 800 milliseconds, I'll say acquire all beats that fall between 700 to 900 milliseconds after the previous RR interval, but discard anything that's too short or anything that's too long when you reconstruct the image. And then I can go from having poor image quality, like this example here, to now having very good image quality, because again, I'm discarding the ectopic beats. So the downside with this obviously is when I'm discarding data, and if I said it takes me 6 cardiac cycles to generate my image, if I'm tossing out some cardiac cycles, then what happens to my breath hold time? The acquisition time gets longer, yeah.
So this trick allows you to get a good quality.
Yes.
However, with HLF, a lot of patients, particularly the elderly ones, because of diastolic dysfunction, they have a lot of EF variation.
Yes. Yes.
You may see them have an EF of 20% in one cycle,
right,
and 60% in another.
Yep.
So how do you tackle that physiologic problem? No,
Yes.
That,
Right.
It's not technical, now that's physiologic.
Right.
Because when you report the EF, you might be reporting the EF that looks too low because it was taken with a short cycle, right?
Right. Right.
So how
And
do you handle that one?
yes, that's a good one, and that's what I'm going to get to the next slide. So it's a very nice setup, because this strategy I think works the best if you're having some occasional ectopy. If you have a lot of ectopy, it's not going to work. If you have AFib where there's a lot of variability and there's physiologic variability, that's not going to work as well. And so in those cases, I'll show you what we will typically do. Actually, that's coming up in a second. So before I get to that, let's just show you the other aspect, which is we talked about, is one is there's a problem with arrhythmias or gating. The other is there's a problem with breathing, right? And so it's important to actually be able to distinguish which is which, right? Because again, both of those will lead to blurry images. But the question is, if it's a problem with gating, the way you're going to try to correct for it is by going in and reposition the leads or changing the parameters. If it's a problem with breathing, you're going to either, one, make sure the patient didn't fall asleep on you, or go in there and try to wake them up, or else try to shorten the time of the breath hold. So by looking at these images, can you tell me which one of these is a breathing problem and which one of these is a arrhythmia or gating problem? And so the key to that is actually not looking at the heart. It's looking at everything outside the heart. And so the best thing to look at is the abdominal structures, right? So do the abdominal structures here look nice and crisp? Look at the borders versus over there, right? Because the heart looks abnormal in both cases, right? But if you look at it on the left-hand side, the abdominal structures also look abnormal. On the right-hand side, they look quite normal. So the left-hand side is a breathing problem. The patient couldn't hold their breath. The right-hand side actually is an arrhythmia problem. All right? And I'll show you another example. Here's 2 cases here. And again, if you look at this, can you tell which is the breathing problem and which is the arrhythmia problem? Okay, raise your hand if you think left is arrhythmia. Okay, raise your hand if you think the left is a breathing problem. Yeah, see, that's pretty good. So you guys are all ready to come rotate in the MRI lab now. See, so I mean, but the key is you have to be able to recognize this to then troubleshoot to figure out the problem. Now, I think, yeah, so next we get to this issue of what about people who have significant arrhythmias like AFib, that's basically all the beats are irregular, or people who can't hold their breath. And then there's a last resort strategy we can go to, which is called real-time imaging. Okay, so what I said is that most MRI images are acquired over several cardiac cycles and put together, so it takes about a 5-second breath hold to give you a high-resolution image like you have on the left-hand side. But we can do a real-time strategy which produces an image like you get on the right-hand side. So what's the difference? Well, the pixel size on the right is about 3 to 3.5 millimeters versus the regular high-res acquisition, which is about 1.5 to 2 millimeters. The other is the frame rate on the right is a little bit slower. So we compromise a little bit on the spatial resolution and the frame rate, but this now is obtained in real time just like you do in echo. So in a case of AFib, this is what we resort to. So we're not artificially picking just a certain set of cardiac cycles that correspond to a certain time interval. Rather, we're seeing everything what's happening in real time.
Then how many do you actually record?
So typically we'll do this for about 5 seconds.
5 seconds.
Yeah, so it's a 5-second window. And then you'll see a lot of times, especially when there's a lot of RR variability, it doesn't make sense to try to give you volumes in EF, quantitatively. Instead, we just report out a visual range of what the EF is, because the reality is the EF varies from cycle to cycle. So, but I think that one other important thing to keep in mind is that because this real time can be applied in anybody, no matter what their rhythm is, and whether they can hold their breath or not, because it doesn't require breath holding, you should never have images that are worse than the right-hand side, right? So that's the worst quality images you should ever see on a CMR scan, all right? So if I always tell the techs, if you give me images worse than this, I'm going to go back to you and say we need to have a little schooling again, okay? So next, we talked about how we actually generate the image. Now let's talk about what we do now once we've generated the image.
The question
Yep.
is, can you get worse images even on the left side if it is not done appropriately?
Yes, on the left-hand side, yes.
what I mean?
Because if you try to do the high-res segmented acquisition, but you don't gate properly, you don't have them hold their breath properly, you can end up with very bad quality images like, remember the examples that we saw here, right? These are cases where there's a problem with breath holding or a problem with arrhythmias, and you're trying to do the high-res segmented acquisition.
Right.
So the point is, it's like that saying, the enemy of good is perfection. Sure, we want to try to use the high-res data sets, but that only is if you can get adequate gating with a normal rhythm with a patient who can hold their breath for the duration of the scan. And so, yeah, oftentimes when we get outside studies, you'll see basically people just try this technique, but they're having arrhythmias or they can't hold their breath, and the images look very bad. What you have to know is that you should always then, if you can't, you try to troubleshoot. If you can't troubleshoot this, always fall back to the real-time images. All right, because that you can do in every single patient. Okay, so once you've generated the image, the question then is, how do you actually compute volumes and compute EF? So as I mentioned earlier, when we do this, we're going to acquire sequential short-axis slices. And so essentially, we're going to go through and trace each individual short-axis slice and summate the volume together for each individual slice. So this is the true Simpson's rule of disk, essentially where it's the area times whatever the thickness or the distance of the slices are, summated together to compute a global volume, both in end-diastole, which is the top panel, and systole, which is the bottom panel that's shown. And there's data now going back, probably 20 years, 25 years, showing fairly tight relationship between CMR computed volumes and, both, in the setting of animals, in vivo, as well as, in fact, casts of cadaveric heart, which show a fairly tight relationship. as long as you get decent quality images and you do the acquisition or the post-processing carefully. So again, accurate and reproducible volumes with no need for geometric assumptions. So let's go through and show you how we would actually compute this. So this looks kind of like a busy slide. What you've got here is essentially a set of images all taken at slightly different slice locations from base of the heart to the apex. And then what we see on the right-hand side as we go from left to right are the different frames in the cardiac cycle. So the first thing, if I'm trying to compute my volumes in EF, is I need to go through and identify all the slices that I'm going to incorporate in my post-processing tracing. So I want to make sure that I go all the way to the base and make sure that I go all the way to the apex. If I miss a slice, especially if you miss a basal slice, there can be a lot of volume that you miss, and you can get a significant underestimation of volumes. Next thing I need to do is I need to look through these, and I just play through these manually and find what's the frame that I'm going to define as end diastole and as end systole, right? So end diastole by definition for the LV is going to be the frame that gives you the largest or the maximum LV volume, and end systole is a frame that gets you the minimum LV global volume. And then oftentimes in cases of dysynchrony, you may have, in fact, a different frame for end diastole and end systole for the LV versus for the RV. But again, if the definition is maximum volume versus minimum volume, you need to frame through these and find the ideal frame. So usually speaking, the way that the acquisition is done, the acquisition starts right at the onset of the R wave. So typically, most of the time, the very first frame that we get is end diastole, but that may not always be the case. All right, so the next thing we're going to do then, I think is important to keep in mind, is to look at all the short axis slices I've got and determine where's the basal frame. Now you notice, in addition to the short axis views that I've got long axis views. And in the post-processing workstation, I'm actually going to load these long axis views in. And because the MR scanner provides a coordinate system, the post-processing software can actually register where that short axis slice is in relation to the long axis slices that we acquired. So I can see that this short axis slice that I've got right here, which is diastole, this is systole, actually corresponds to this location right here in the middle of the ventricle. I can see where it sits in relation to a 4-chamber, a 3-chamber, and a 2-chamber view. And I'm going to make sure again that I've got all the slices that go all the way from the base all the way down to the apex. And then the other important thing to keep in mind is, let's get forward here, that notice what happens during systole is that there can be a significant amount of base to apex descent. Now, I can have a slice, for example, this slice right here, which corresponds to this location, which in diastole is clearly within the middle of the left ventricle. But notice what happens during systole. As the entire basal planes descend down, that slice now during systole is no longer part of my ventricle. And so frequently when you do your tracing, you'll actually have a slice that you'll trace the volume for diastole, but you will not trace that volume for systole at the very base. All right? And this is a common source of error. If people are in the habit of just saying, okay, I'm going to trace diastole and systole for every single slice location, then that will lead to, again, an error, an underestimation in your stroke volume and your EF. So it doesn't affect the EF that much, but it causes a significant error in your stroke volume. And then this is where it can have a major problem then if you're trying to look for valvular regurgitation to quantify.
So
How do we determine that?
No, the line is not a line. Obviously, you have about 8 millimeter thickness.
Right. So,
right?
yes.
So
that line, yeah. So the way it works is there's two ways you can do it. You can actually have it, this represents right here the middle of the slice, or some post-processing tools will actually allow you to basically have a 2 lines, which will tell you where the top of the slice is, where the bottom of the slice is. Whoops, sorry. And essentially what I'm going to do is say, okay, is this slice right here underneath the mitral annulus, or is it above the mitral annulus? Now the question you've got here, which is a good one, which is if I look at this slice right here, it looks like, and again, if I take these are 10 millimeter slices, then half of it's below and half of it's above, right? So there's 2 ways to do it. There's one way, which is a manual way, which I would say, okay, for this slice right here, I'm only going to take whatever the volume there is and just trace half of it. Or some of the more recent post-processing algorithms actually allow me to basically place a dot here to tell the algorithm that that's where the base is. So if I have a slice right there, it will manually determine that the location I specified right here represents half of the slice, and then I would trace the volume, but it would then just compute half the volume for that specific slice location. So there's two different ways to do it, manually or automated. Okay, so the important thing to keep in mind is that the amount of base to apex descent that can occur is in fact on the order of about 1 to 2 slices. So it can be quite a bit. All right. The other thing that's also important to keep in mind is what about the papillary muscles? All right, because the papillary muscles themselves actually have volume, right? They have, and so depending upon how you trace the papillary muscles and the trabeculae, that could represent anywhere from 6 to 9% of LV mass, as well as LV volume. So there's not a specific convention, by societal guidelines to say should you include them or not include them. There's, some post-processing tools that just kind of ignore the papillary muscles, so they would essentially just trace the LV contours here and consider the papillary muscles as being a part of the blood pool. The downside with that is then you're assuming that these PAPs are actually part of blood volume, so it causes some slight errors in estimation of volumes, and that can lead to a slight source of error in ejection fraction. The key is really that you need to have a convention in your lab, because you don't want to do it one way one time and another way another time. So the preferred way that we like to do it, and this is based on the fact that most of the normal values that we have for LV volumes and EF are based on excluding the papillary muscles. So I'll show you now the way that our post-processing tool works right here. So it's actually fairly easy because, again, when you have fairly high quality images, there's a pretty good SNR or pretty good contrast between the cavity and the myocardium. So all you do is pick a dot in the center, and then it's essentially just a region growing algorithm. So you let it grow until you identify where the contours are, and then stop. And then literally it takes just a few seconds to do. So I think nowadays, if you ask the techs, most of the post-processing can be done within a few minutes, within 5 to 10 minutes at most. So I think a couple of things to keep in mind is that you want to make sure that you, for your laboratory, before you start, practice on normal volunteers, right? To make sure that the way that you're doing the tracing, the way that all of your techs are doing the tracing is the same. And the advantage when you're doing it on normal volunteers is your LV volume should equal your RV volume, right? Because the stroke volume of the LV and the stroke volume of the RV should be the same. And also, we have phase contrast techniques that allow us to measure flow in the aorta. And that's another quality check that you do amongst normals, is measure what is the stroke volume that you derive for your left ventricle by this planimetry compared to what's the measured aortic flow by phase contrast. Now,
You mean stroke volumes, obviously.
stroke volumes, right. No, not end diastolic volumes, but the stroke volumes. Yep. Now, the other thing that's important to recognize is you want to make sure you have normal reference values. So there's actually several series that have been published which provide normal reference values for the typical imaging sequence that we utilize, and they break it down by deciles of age. So the important things I think to keep in mind is if you look at, for example, LV end diastolic volume, which is shown here in the highlighted area, and if I look at the upper limits of that, this right here at the bottom gives me the range of values, right? The lower limits of the 95% confidence interval and the upper limits. You'll notice that the upper limits for LV end diastolic volume can be as high as 101 milliliters per meter square for young patients. And then notice what happens to the upper limits. It gradually gets smaller. As you'll notice what happens to the mean value, gradually gets smaller. So hearts over time tend to get smaller slightly with aging. And so one of the common areas where this is an important issue is oftentimes in young patients, unless you correct for their age, it can seem like they have a big heart. But you don't want to give them pathologic diagnosis. In fact, when normal young patients tend to have slightly larger volumes than older patients do. And this is just showing, in fact, what happens to normal values. The mean, as well as the upper limit of the confidence interval, gradually goes down with aging. What happens to ejection fraction? If you look at ejection fraction, there's a tendency to have the ejection fraction actually goes up a little bit with aging. So for young people, the mean was 66. For older people, the mean in these normals was 69. But what's most important, if you look at the lower limits of normal, for young people is as low as 57, whereas for older people, the lower limits of normal is 60. So again, this is a little bit different than echo, I think, where they use the lower limits of normal of maybe in the low 50s. Really, the lower limits of normal by CMR is in the high 50s to 60. And then also there's differences between men and women. And so typically you'll see in the MRI laboratory, we actually have 4 tables up. Normal values by age for men, as well as for women for the LV, as well as for the RV. And then before you say something is dilated, you want to make sure that it's outside of the normal reference range based on both age as well as gender. Okay, and then obviously these values, if you look at kind of the upper limits of normal for LV end diastolic volume for men or women, are a fair bit higher than what we're used to typically by echocardiography, where the values, the upper limits of normal, are a fair bit lower. So again, you need to make sure that you use normal reference values for the technique that you're utilizing. And we'll get into maybe why there might be some subtle differences between measurements by echo and CMR. So a couple of things, kind of what are the take-home messages? One is that normal volumes, LV volumes, will decrease with age. Normal LV ejection fraction tends to increase with age. That normal volumes are different between men and women, and that normal volumes by CMR are different than normal volumes by echocardiography. So I think you need to recognize those differences. And then this is one of the studies. There's several studies that have kind of tried to probe into why are there differences. This is one particular study which looked at, this is out of Roberto Lang's laboratory at University of Chicago, looked at comparing volumes by 3D echo versus volumes by CMR. And although there's an overall relationship, what they found, in fact, was that when you look at end diastolic volumes by echo, when you look at a bland Altman, there tends to be a little bit of a negative bias, so that the echo values tend to be a little bit smaller than they are by CMR. And again, these are not normals. These are a series of patients that they looked at. And so for this publication, this is a few years ago, they actually did actually before I get to that, this is also a meta-analysis looking at multiple different studies that have compared CMR-derived values for LV end diastolic volume, end systolic volume, and EF, compared to those derived by CT, those derived by 3D echo, 2D echo, or 2D echo with contrast. And what you'll notice is that for all techniques, the EFs tend to be about the same, right? So CMR EFs tend to correspond fairly closely with what you get by CT, what you get by 3D echo, what you get by 2D echo with or without contrast. Where the biggest differences, though, tend to be in LV end diastolic volumes, where there seems to be a negative bias for plain old 2D echo, which gets a little bit less when you give contrast, and a little bit less when you give 3D when you do 3D echo. And then by CT, the CMR and CT values seem to correlate pretty closely, both for end diastolic volume, end systolic volume, as well as for EF. So in this particular study by Roberto Lang's group, they actually kind of try to figure out, well, what could explain some of the sources of differences. And so they actually went back and got some just water-filled balloons, so they know what the true volume is. And I think one of the big questions really comes down to, when you have a interface, there's some thickness to this interface. And then depending upon where you trace, whether you trace the inner border, the middle border of the interface, or the outer border, can actually lead to a significant difference in the volumes that you generate. Because again, if you just add a little bit of volume along the very outer edge, a little bit of area becomes a very large amount of volume. And so what they did then is they said, okay, it's interesting that there was this kind of negative bias or difference between echo and CMR for LV end diastolic volumes. And then they speculated that could this be due to the issue of the trabeculations, which sometimes can be hard to resolve because of the lateral resolution on the echo. And so they went through and actually said, okay, let's trace the CMR now, ignoring all the trabeculations. So we'll trace along the inner border like they did here. And they found, in fact, that the correlation became tighter when they did that, both for end diastolic volume as well as for end systolic volume, and then the negative bias actually tended to become much less. So their hypothesis was that the negative bias that you see by echocardiography compared to CMR or CT may in fact be due to the issue of volume that's present along the very lateral trabeculations within the ventricle.
See, the concern is still, despite that, volumes by echo will always be smaller. So you take a look at, so you see a correlation, that's why we talked about it before, a correlation doesn't give you the whole thing. Take a look at the equation. Y equals 0.69 and 0.7, right?
Yeah.
Meaning that it will be smaller, right? Since Y is the echo portion as opposed to X. Yes, you have a little offset of 33 or 22, but the linear relation tells you that you will always underestimate. And if you don't mind going back a little bit, go back
Yeah,
to
so
the
this one they
blend
found
open.
the bias here was 14 versus
when you if you trace it differently, if you ignore the triangulation, then the bias
became about 1%. So if we go back to the bland Altman, here. Yep.
So you watch what happens. So you could take a look at the blend Altman, but always look at the actual data, right? Look, right, there's a negative, right? So overall, you're underestimating. But look what happens as the volumes get larger. As the volumes get
becomes
larger,
magnified.
your underestimation becomes even bigger, right? See how the dots are going in that direction. So you could take a look at the mean bias, but the mean bias doesn't tell you the whole story.
And also, DIPAN, I know you didn't show the FHO volume.
Yeah.
I wouldn't explain the difference, right?
When,
Yeah.
FHO volume difference.
Right, so
Left
left
atrial
atrial volume
volume
also, normal values by CMR
are
are
about 50 milliliters per meter square, by CT as well. But by echo, I think the upper limits of normal is about 34. So there's a big difference there as well. Yep.
And go back, Deepan, if you don't mind, to the one more. Okay. This is how you're going to tie what you learned last week, I guess, what was it, echo, right? And lateral resolution to this. So this is a balloon. I don't know what kind of material the balloon was from,
Rubber.
right? Rubber or whatever it is. But remember that the lateral resolution issue of ultrasound is a big thing. So if I have a phantom with a pin, just a pin, okay? In the lateral resolution portion, a pin would look like this guy. It has lateral issue, right? So just imagine you have the endocardium here. The border is actually in the middle of this thing. It's not on this side. And it gets worse the further out you are, right? So closer to the transducer, the lateral resolution is lesser of an issue. But just imagine you're trying to do left atrial volume. That's why, I mean, you see the cavity dark, but the question is, where's the border? And the larger it is, the larger the cavity is, the worse your underestimation, just like you saw. Why? Because 1 millimeter or 2 millimeter on a large cavity is like 20, 30 cc's. Right?
No,
So I think the key is that you don't want to just
apply normal values across different modalities. You need to know for each modality what their normal reference ranges are and use those, because there are differences between techniques. And then so lastly, this is what kind of the appropriate use criteria say. When would you refer a patient for CMR for assessment of LV function? And so obviously in patients with congenital heart disease where you want accurate assessment of LV and especially RV function, and we'll talk about the RV later on in the year because that's a whole separate discussion, I think, in and of itself. Also in patients post-MI or with heart failure, especially when there's suboptimal quality echo images. And then lastly, when there's a discordance, when, for example, by nuclear you've got an EF of X, but by echo you've got an EF of Y, then there may be a role for CMR to try to help discriminate between the two. So let me stop here, and then let me have Sumin take over to talk about CT, and then we'll wrap up with some questions at the end.
Dr. Shah, I have a question. Is there any reference normal values for CMR for athletes?
For what, sorry?
Athletes?
For athletes?
Yeah.
Oh,
Can go to go down. Keep going down. I just keep playing. Okay, just real quick. Obviously, cardiac CT is almost never be your first choice for LV function assessment, but in very rare occasion, I think we use CT. But first, instead of going through all the potential pitfalls, advantages of CT, I think it's important for the fellows to understand first what are the scans protocol, okay? Because oftentimes, you get some physician get a CT scan and might ask you most of the time for the coronary or the cardiac structure, but you need to be able to understand the scan the protocol you use. Are you able to obtain LV function? Or the other way around. Let's say someone order a CT scan for certain indication. Do you want to do certain protocol so you can also get the LV function, LVEF, which we know that add tremendous diagnostic and prognostic value, okay? So I'm going to talk about, probably spend a little bit more time in scan protocol. So the most common the best way of getting LVEF is doing a retrospective ECG gating without dose modulation. So essentially, it's similar to MRI. We use ECG gating, so basically we stitch different part of cardiac cycle obtained in each scan when you go around the heart, and we put them together. So unless we have a whole heart coverage white detector CT that Dr. Nabi mentioned last time, which allow you to acquire the whole heart in one single cardiac cycle, you're going to have some type of stitch artifact. But the main difference with CT compared to CMR is a true 3D acquisition. So you can go back. You don't have to prescribe any specific axis. You can just acquire the 3D data set, and then afterward, do the processing. You can orient it, reconstruct to the axis you want. For instance, right here, the top portion is the actual image. That's what you see when you open the CT scanner, when you open the images in the workstation, and then you can do multi planar reformat and to orient to the axis that we are very familiar with, especially from the echo, epoch 4, epoch 2, and short axis to assess the volume and ejection fractions. So best way is obviously doing retrospective gating. Basically, the detector, the source of energy is on the whole time during a cardiac cycle. You get beautiful images like this with good timing. Typically, with the heart rate of around 60, 65, what we aim for cardiac CT, dividing the cardiac cycle into 8 to 10 phases will get you a reasonable diagnostic ejection fraction. So So this will be the most common way. The downside is obviously the radiation, because you have the X-ray source on all the time. So then comes to what we call ECG gated, also retrospective gating, meaning the detector is on the whole time during the cardiac cycle, but during the part of the cardiac cycle we're less interested. For instance, if you look on the coronary artery, which most of the time mid-diastole is where we're interested, the rest of the cardiac cycle we can turn down the energy level, usually, and the old scanner is about 30 to 40% of the scan. So you can save, in general, about 25 to 30% radiation dosage. As you can see in the left-hand side in diastole, the images is much, signal noise ratio is much better than the right-hand side. Doing systole, that's when we turn down the energy, for instance. To take it a little bit further, but despite this, you can see very well, you can still see the contour, the separation between the LV cavity and myocardium. So for LVEF and volume assessment, study has shown is still quite accurate compared to retrospective gating without dose modulation. And this will be another example of a retrospective gating with dose modulation. You can see, what can you tell from there? I don't know why it's not playing, but this, for instance, essentially this turned down, energy level is turned down to less than 20% of the maximum energy during diastolic phases. And there's tricks that you can do to still obtain reasonable contour and assess the LV function. Well, I need to play this for you to see. Global function. Okay, where is my cursor? None of my clips are playing. Okay, none of my clips are playing. Okay. It was playing in my laptop. Oh well. Okay, then, the other scanning mode is prospective gating. Okay, so in the old days when we started prospective gating, the idea is to just have the detector on during specific part of the cardiac cycle. For instance, doing 70% of the cardiac cycle. With the newer scanner, it allows you to open up the window called padding. So instead of only during the rotation, scanning time 200 to 160 210 milliseconds, the gantry rotation time allows you to open up a little bit longer. So essentially, you can open up during the entire cardiac cycle to the extent that you can open from 30% to 90% or 95% of the cardiac cycle. So for instance, like this case, we have it open from 20 to 80%. So you can see we don't have the entire cardiac cycle. We're missing part of the late diastole and early systole, but you can still calculate the ejection fraction. Might not be able to evaluate diastolic function or systolic function, but you can still get a reasonable ejection fraction. So how do we calculate volume and EF? So 2D method is very simple. It's very similar to MRI. So you either use area length methods or use the Simpson method. So, and the correlation we talked, I'm not going to repeat that, as Dr. Shah already mentioned. Then I think what's relatively unique with CT, if you have good signal, you can take advantage of the difference of signal contrast intensity between the left ventricle cavity and LV myocardium, and this is almost completely automated. I'll show you an example later. So the 3D method between 2D method, the slight differences, but overall very good correlation. For CT, most of the time, with most of the algorithm, we include pop muscle inside the LV cavity. I think it's just easier, I guess. So this is kind of the workflow. I mean, so for instance, the left-hand side, that's what you open when you reorient the cardiac axis. And the computer software work in the background. This is all automatic, generated into 3D volume data sets, 3D color coded in different part of the cardiac chamber. without any interface between you and the software. So this is completely automated, and this is what you get.
Usually, if you're doing the threshold-based method, then it's going to basically ignore the pat muscles, right?
Depending on I think the software is designed only following the border. Yeah.
Into all the crevices.
Yeah, exactly. Yeah, so we cover also the pop muscle. So again, we generate a time volume curve. In this case, we only reconstructed 10 phases. If we reconstruct the cardiac cycle into 20 phases, usually you get a higher ejection fraction, which is true or not. It's open for debate. So again, this is completely automated. I think the interesting thing is, I mean, the software has gotten so much better that if you look at the right ventricle, you can see the signal, I mean, is quite suboptimal. But despite that, I think with artificial intelligence involved, I think the software is getting much better. As you can see right there, RV function assessment was actually quite reasonable. And this is using symptom method. As you can see here, the same problem with MRI, depending where you put your apex and mitral valve plane, you can change and vary LV volume and LV ejection fraction. Okay, and the caveat obviously is the main problem with the CT is the temporal resolution. Okay, so MRI has at least 20 to 30 frames per second. CT we get at most 10 to 12 in the best cases. So you can tell that we have a problem in actually detecting the true end-systolic and end-diastolic volume. Therefore, ejection fraction is going to tends to be lower by several points compared to CMR. And the other caveat is, again, arrhythmia is still a problem. We cannot do the real-time imaging yet, but people are working on that. And the caveat of 3D method is obviously because of the step artifact due to arrhythmia, for instance. And this Dr. Shah already mentioned this. This is the correlation between CT and CMR, especially for the lower part is the newer generation scanners. The relationship appears probably not very different, but overall very good correlation. And this is just an example of left atrium. As you can see here, the difference between left atrium between CT and MR is also almost, although significant, but the number is very small, and would compare to 2D echo underestimate significantly compared to CT or MRI. But I think the most important thing, the inter and intra-observer availability is much better, obviously, with CT and MR because of the better spatial resolution. I thought it was interesting to show you guys this. I mean, this is people have done, try to use CT to evaluate diastolic function, not because it's more accurate, but I thought I'd show it to you guys to see, to show you guys there's a lot of information you can derive from a CT data set. So how do they derive, how do they calculate the E velocity, through the mitral inflow? So if you have a reasonable time volume curve, you can actually convert them into a velocity, like by the left-hand side here. And since we have good spatial resolution, and if you have a patient with slow heart rate with reasonable temporal resolution, you can actually calculate the annular, how much the annular is shortened by measuring the axis of the left ventricle during systole and diastole. So the difference would be the excursion of mitral annulus. And you can trace the mitral valve area. With that, technically you can have mitral annular velocity. And the study has shown compared to the Doppler, the correlation was reasonable. So that was an interesting concept. Not necessarily we would do this routinely, but just to stimulate the things that we could do potentially with the CT data set. Just briefly, just to show you guys that some people are working very actively with strain imaging. especially, I think we're interested in this not because we want to do strain in routine in patient with CT in routine patient, but for instance, patient with LVAD, that's a population we're very interested in, especially the RV function assessment. I think CT will be had potential, and this is the first thing we try with the Siemens using their Echo software and using our CT data set. It appears to work. This is the first step. So, if any fellow who's interested. So if any fellow is interested in working on these projects, I think that's especially patient.
From the video.
Yeah, there's a background from the video. This is a picture. Yeah. Yeah. I should mute it. Yeah. Anyway, this was published several years back, and I haven't heard anything because the main problem in the strain with CT is the frame rate. Okay, because you really need to have good frame rate. This image was published almost 4 or 5 years ago in JACC Imaging. Nothing has come much out of it, but there's a supercomputer analysis which you can kind of not guess but estimate by measuring where a certain part of the cardiac structure in the beginning of the systole and diastole, and kind of guess what the trajectory and what will the structure would be in different part of cardiac cycle. So instead of having 10 or 12 cycle phase per second, you can interpolate up to 50 phases or 40 phases. You can see the contraction and transition is much smoother. But I haven't seen anything come out recently. But it will be something interesting in doing, especially for RV function strain assessment in patient with LVAD. So basically, volume and EF assessment by cardiacity is feasible and fairly accurate compared to MRI and echo. But again, the main idea message I want to transmit to the fellow is you need to know if the LV function assessment is required, what kind of protocol you're going to prescribe, depending on the radiation dosage and depending on the contrast and the renal function and the question. Specifically, right now we're doing a lot of valvular function assessment, so oftentimes that require information from different part of the cardiac cycle, and you will get the LV function, and you need to know how to quantify and assess. And next time we can talk about more in detail what kind of factor affect the measurement of the volume and EF. That's all I have. Question?
Okay, thank you.